All right, well, it's really a pleasure to be here. And so my job is to give you the hospital side, to show you the really important stuff. And so I operate a hospital transfusion service. And my job is to make sure that the transfusions that we provide to our patients in need are the safest. And what I hope to be able to do in the course of this presentation is to show you how important some of this evolving new technology is in terms of that charge, making the transfusion as safe as it can possibly be. Now, there will be an exam at the end of this talk, but what I wanted to do is to give you an idea basically initially is what is it that we do in terms of testing on a routine basis to ensure the safety of the blood recipient. So we test for 3 antigens or 3 elements within the red blood cell, the A and B antigen on the ABO group and the D antigen in the RH group. Well, then you ask the question, well, how many antigens are there? Well, there are greater than 350 antigens on a given red blood cell. And as you know, as individuals, we're all quite diverse, different in terms of our composition. And especially in the US, where we have different populations, one might say we're hyper-diverse. And therefore, that really represents a challenge in terms of when you transfuse that individual and you've only matched for 3 antigens out of the 300, 1% of the total, that represents a biological challenge, and some might say an experiment. Now, the good news is that the majority of patients who receive a transfusion with this limited degree of matching will not form antibodies, will not mount a response that will make them at risk for serious consequences. That is, 1 to 5% of the usual recipient pool form alloantibodies or mount an immune response. However, almost 1 in 2 at the highest estimate of patients that are chronically transfused, anywhere from 12 to 39% of chronically transfused individuals will mount a response. And so really the question, this is related to the volume of transfusion. As we look at the intensity and who forms antibodies, we can see a correlation between patients who are receiving more units having a greater risk for alloimmunization. And so really, the challenge is what groups benefit most from higher grades of matching. And what I hope to be able to do is at the end of this talk is to convince you that there are several groups today who would stand to benefit from having a higher degree of matching than we offer in our current testing scheme. So let's talk about the first group, patients with sickle cell disease. All of you know, you've heard of sickle cell disease, right? Okay. Well, there have been major trials that show great benefit in terms of transfusing patients that have sickle cell disease in terms of reducing morbidity, reducing mortality. And what I show you today represents information from the STOP-2 trial. Now, this is a trial where they looked for patients that had sickle cell disease that were at risk for CNS or stroke and brain injury. And so they transfused those patients, and what they saw during the course of the study was that those patients that received transfusions were protected. However, at the end of the trial, all of the patients that received transfusions did not have the transfusion therapy continued as per protocol, because again, it was a trial to see what the effect would be. And what's striking is that in those individuals that continued transfusion, about 8%, a little bit less than 10% developed lesions. And some 30% in the group where the red cell transfusions were stopped developed lesions. Now, what are we talking about? Well, these are very significant brain injuries that can lead to cognitive dysfunction, they can lead to stroke, and they can even lead to death. So it's clear that patients that have indications for transfusion, chronic transfusion therapy, and sickle cell disease are in essence transfusion dependent and therefore are dependent on receiving red cells to improve the quality of their life. So what happens to the chronically transfused patient with sickle cell disease? Well, Dr. Vachinsky and colleagues years ago did a very nice study looking at the adverse outcomes in terms of forming antibodies in these individuals. And 1 in 3 chronically transfused sickle cell disease patients are at risk for alloimmunization and therefore adverse consequences related to such alloimmunization. That is, they mount a response to the cells that are transfused, And that response can lead to, it can even lead to life-threatening complications. It's not a small issue. Now, the more antibodies, the harder it is to find a matched unit. And that's something I think that you need to keep in mind, because most of the units that are tested currently have limited testing. And what we're talking about is a platform in terms of the new diagnostics that would give us expanded capabilities in terms of the matching that we need at a higher level for these patients. And what you can see in this chart here is that, so in his study, most of the antibodies were directed against elements in what we call the KEL and the RH system, so that a standard, a guideline that emanated from this study, and it's a current matching recommendation, is to match patients for RH and KEL antigens. And so this is done in many centers. It's done using a method that's not akin to molecular testing. It's less specific, it's a little less accurate. And what you can see is that subsequent studies from the University of Pennsylvania looking at sickle cell disease patients who received units that were matched using serologic techniques for the RH and KEL antigen continued to make antibodies, continued to have problems associated with the transfusions. And so this points to the need to have a more robust technology, a technology akin to the molecular diagnostics that my colleague, Dr. Moles, will tell you about later. So, is sickle cell disease the only group at risk for transfusion? No. What we can see here is, and as I'm approaching 65, I'm feeling it more and more. There's a high prevalence of bone marrow failure as we age. Your bone marrow turns over constantly. And as you age, the ability to regenerate cells in some individuals really falls off. And those individuals develop what we call bone marrow failure, or the myelodysplastic syndrome. And the reason for this slide is that the published rate in well-designed studies can show that really underestimate the true incidence shown here by as much as double. It's almost double the published rate. And if you look in the elderly, it's a highly prevalent disease in those individuals over 65. What about their transfusion dependence? What we can see is that about a third of individuals that have this disease are transfusion dependent. Further, of those individuals that are transfusion dependent, a third of them become alloimmunized. So here's another large swath of our population that requires support with red blood cells who are at risk for forming alloantibodies. Again, our limited scheme that we use today could be improved for certain groups of patients, i.e. those that are chronically transfused. So the benefits in Dr. Katz's shop in terms of using these molecular types would be expanding the availability of highly matched units for these patients that need the product. It would also allow us to have units that are extraordinarily rare. It's very hard to find units that may account for maybe 1 in 1,000 or 1 in 10,000 individuals, but by typing the inventory that we have more extensively, we'll have greater access to those units. So again, we'd have increased not only in highly typed units, but an increased access to units that are particularly rare. Untold, in terms of the red blood cell, there are other advantages that extend to maternal and fetal considerations, and that is there are situations, and I don't know if you know about hemolytic disease of the newborn, but a mother who's Rh negative can form antibodies against the fetus. And these fetal DNA typing approaches are very useful in terms of our ability to manage patients with at risk for hemolytic disease of the newborn. Further, there's a catastrophic bleeding complication related to platelet typing. And we haven't talked much about anything other than red cells, but these platforms will also allow us to be able to test patients for platelet injury, potential for platelet injury. And I can tell you in some Scandinavian countries, the population is scanned or the population is tested to see who's at risk. And this is a very severe complication that causes intracranial bleeding and death and severe decompensation in neonates. So what is the proof that this methodology has an impact? Well, in those places that have been using this in research use only mode, that is in a non-approved mode, what you can see is data here from the American Rare Donor Registry program. And the number of units that they are able to provide once they started using the genotyping platform in terms of liquid units made available, the number really, in essence, skyrocketed up to approaching 90% from around 30%. So this is evidence that this robust method can expand the availability, expand the access to these important and rare units of blood. So in sum, there are transfusion-dependent patients, patients with sickle cell disease, patients with thalassemia, patients with aplastic anemia, patients with myelodysplastic syndrome who depend on transfusion for their quality of life. We know that these patients, when they receive units that are not more extensively matched, can develop consequences. And what genotyping offers is a more accurate method for highly matched units to avoid the complications in those who depend on the product. And I'll stop there.